So thank you very much for joining, and thank you, Anna, for your lovely introduction. Yeah, I'm James. I'm a HEMS doctor with the Air Ambulance Service in the Midlands, and I'm also a paediatric anaesthetist. I don't usually classify myself as that, but I got in trouble for not saying it. So I'm a paediatric anaesthetist based in Derby, and I'm going to talk to you. I also run something called KidConfident.org, and I'm going to talk to you about the KidConfident approach to paediatric trauma. So all we're going to talk about basically tonight are the differences between adults and pediatric trauma patients, the ones that actually matter and why they matter, and then go through a bit about the assessment of peds trauma patients, important primary survey findings, treatment, and a little bit about scene management. But the whole point of this is to give you confidence to manage injured children in your day-to-day work. So have a little think about why children do badly after major trauma. It comes down to missed injuries, and that's a lot to do with having a high threshold for CT imaging, children not telling you everything, under resuscitation, coagulopathy, and then this whole pediatrician versus traumatologist sort of battle that goes on in the hospitals. Now, most of this is nothing to do with pre-hospital care, but it's things just to be aware of, and just to remember when you have a child that does badly after trauma, it probably isn't down to you. But the thing that they're treated like an alien species is a really big thing, and it brings me onto a rant. And I'm sorry if you've heard this before. Sorry, not sorry, but the message we all get from pediatricians are that children are not small adults, and we should be very, very afraid of sick children. We need to do everything different, and they're all very complicated. And this winds me up because actually, the message that we should be told is that children are actually like small adults in some ways. Then there are some important differences, I can't deny that, but we shouldn't be scared of them. And basically, when all the cards are down, and you're dealing with trauma or resuscitation, and your brain goes blank, you won't go far wrong by scaling adult care to size. And if you don't remember anything else from tonight's webinar, then that's the message I want you to take home, because it makes more of a difference than you would think. So we can't do a lecture about peds trauma without looking about incident, and we mentioned the TARN data. So Trauma and Audit Network, they look at statistics and write reports like this one, which come out every 2 years. The last report that was available is for the period 19 to 20, and it was published in 22. And basically, in that period, there were 4 million children's ED attendances after injury over a 2-year period, and only 0.1% of them had injuries that were bad enough to need a hospital admission. So it's a really, really small number, especially when you compare it to adults. 0.2% of all major trauma deaths in that period, which is deaths with trauma injuries with an injury severity scale over 15 and age under 16, were children. And this represents 3.4% of all severely injured trauma patients. So it's a tiny, tiny number. And when the clever statisticians put that into their models and everything, they work out that the average paramedic on a road will see major pediatric trauma once every 3 years or something. You can see here from the outcomes and the number of deaths that actually kids' outcomes are getting slightly worse, not better, whilst adults are improving or stable. And that's concern to me, because kids should be harder to kill because they're programmed to repair and regenerate and grow, not to succumb to injuries. So what's different? These are the main headlines of what's different with children and adult patients who subject to trauma. And mechanism of injury is one of the things. So the percentage of children injured from RTCs is the most common mechanism of injury, as opposed to adults, which is falls. And then interesting to see that 13% of the patients that were injured, all causes, all mechanisms, were injured intentionally. And that's been recorded as suspected non-accidental injury or parental abuse. and that is much different number to what you find in adults. So, as I said, from the outcomes, 8.4% mortality, which is less than a 13% mortality for adults. But remember what I said about how kids are programmed, and remember there's much less body damage from fags, booze, and years of kebabs as well. Asphyxia and drowning deaths uh, massively increased in 2019 and 2020, with asphyxia killing more children than road traffic collisions. And this also correlates with an increase in childhood self-harm in the same period, which might be something to do with COVID. But you can see as well by the injury mechanism of age that the mechanism changes with the kid's age. So it's suspected parental abuse is the 50% of um, mechanisms for children under 1 year old, but then after the age of 2 it doesn't really feature, and the incidence of injuries from road traffic collisions and falls steadily increases. Well, falls looks about similar and gets a little bit less when they get into the teenage years, but road traffic collisions definitely goes up, and that correlates with the sort of activities that children of different ages will take part in as well. From all these graphs and everything, we can see that road traffic collisions and asphyxia kill the most children, but asphyxia and drowning are the most reliable killers for children. So some more demographics, as I've already said, about 23% of severely injured children were under 1 year old. It's not a new statistic and it wasn't locked down. It's something that's consistent throughout the years in these reports. And then the next highest age group are sort of 15-year-olds because they're really engaging with risk-taking behaviors and going out and being older than they should be. And sadly, children are most likely to suffer or die from traumatic injuries during the first 4 months of their life. And even more sadly, that's most likely to be at the hands of their parents or carers, so suspected parental abuse. Boys more than girls as well, which probably isn't a massive surprise either, especially if you've got kids, you can understand that. So why is this so different? Why is the mechanism slightly different? And it's something to do with the body proportions of children being different. So when you're born, your head is 25% of your total body, and you don't really have much of a neck, and your shoulders are really weak, and your spine takes up a different proportion of your whole body area as well. And then as you grow, your neck starts to develop, your shoulder muscles get a bit more developed, your head shrinks in proportion to the rest of your body. And so then when you get to adulthood, you've got a much smaller head, strong neck muscles, strong shoulder muscles, and that affects how you get injured in different areas. So shows why the most common type of injury in children is head injuries. So then another difference is these calculations for everything, isn't there? We're obsessed with calculating fluids, blood, drugs, and everything else by body weight. And that's extra stress that we don't need when we're maxed out and worried about having to see children. It's the hardest thing to estimate and measure at times, and these complicated calculations that keep changing. And this is just one of our posters. It's our first poster actually, just telling you a little bit, a few of the tricks to try and calculate kids' weights from their age. And you can see that the APLS formulas, which change every few years, and then some other quick ready reckoners, so you can use your hands to calculate, get a rough guess, and that's within a couple of kilos of the APLS calculations. But then children aren't all the same size, they don't read the books, they don't read the calculations, and the picture of a kung fu ninja in the middle there is my Joe, and he was 6 years old. His calculated weight by APLS was 25 kilos, but he wore clothes that for an 8-year-old. So if you calculate his clothes age weight from 8 years old, because that's the age of the clothes he wears, it comes out at 31 kilos. And when you weigh him on a set of scales, he's actually 30 kilos. So you can see there how that feeds into under resuscitation, because if you calculate off APLS, then you're just going to give him 25 kilos worth of drugs and fluids and blood. But actually, he needs a little bit more than that. And 1 kilo is not significant overestimate for him. What we do to try and work around these differences is this wet flag sort of thing, and we can work out the weight using the standard APLS calculation based on their age, or we can use their clothes age to calculate a weight and get a number in kilograms. And then we have the energy for defibrillation, endotracheal tube size, fluid boluses, adrenaline doses, and glucose doses, and that covers us for most of our resuscitation um, requirements as well. And this is something that we can do on the way to a job. If you're driving, obviously you can't, but your crewmate can calculate these things. And we've got these little preparation cards available on the website, which you can download and print and use, which you might find helpful. So then, just to make this even more complicated, normal values are different as well for each different age group. And that is a real drain on bandwidth and trying to figure out the right ones and doubting yourself that you've got the right calculations for all of them. It works for equipment sizes as well. They're different. Blood pressures, heart rates, respiratory rates by different age groups all change. And so we need to use something to help us with this. I use Kid Cards, and the link is on there, and there's a little cheeky discount code for 10% off. As well. I find them really useful. It covers all the drugs, common drugs that we would use pre-hospital, and it also covers all your different equipment sizes for different age groups. But then you've also got your JR Calc apps, or you've got your pocket books, and this little quick guide as well on the KidConfident website, which can be helpful. But even though that's my website, I still use a Kid Cards because I find that I find that easier um, to just turn a card over and figure it out. So we've got quite a few things that are different in children versus adults that can put a drain on our bandwidth, and these are memoirs basically are the way forward to help us work around this. So then we hear this from pediatricians all the time, don't we? That the kids, they will compensate till the bitter end, and then they just crash in a heap, and we can't get them. And we have to work really hard to get them back. But to go with that, they do compensate really well, and then they do fall off their perches. But if you catch that happening, or you catch them early when they do fall off their perch, you can usually get them compensating again really, really quickly. And that's an important thing to remember, because you don't want to be filling your head with doubt and scolding yourself when they do fall off their perch, because you can always do something about it. This picture is a boy who was found in a collapsed building in Chechnya 3 days after it was bombed. This is in the 90s. He had really severe injuries, his burns, inhalation injuries, multiple fractures, and he survived another 2 days in the hospital, interacting with his carers, but then he suddenly died. And the cause of death was a slow subdural hematoma, and he had too many distracting injuries, so nobody picked it up, and they didn't have access to CTing as quickly there. Um, so that's something that could have been fixed, but it was missed because of distracting injuries. It's not a pre-hospital problem, but it's just to show you the resilience of some kids who can be trapped in a collapsed building for 3 days and burnt really severely, but still managed to survive. And with the changes in trauma care in hospital now, I think his subdural hematoma would have been picked up earlier. He would have been monitored differently, and he could potentially have survived. So just remember that they are resilient, they can compensate really well, and if they do fall off their perch, you can do something about it. So let's talk about assessment of pre-hospital pediatric trauma assessment. This is familiar to all of you, know, CABCDE or March if you're from the military. Same, but different. The same things kill kids as adults in trauma, and the priorities, the order in which they kill them is the same in children as in adults. So our assessment of children who've had traumatic injuries is the same as adults. There's nothing different from it whatsoever. We need to find the important things, which is airway obstruction, massive bleeding, and head injuries, which we mentioned are the highest cause of death from trauma in children. This is my favourite football team, Atom FC, after Crystal Palace, of course, which is the best football team ever. And this is just a way of reminding us what our priorities are in a pre-hospital primary survey, and it's to find the immediately life-threatening problems, and that is airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, which we can't really do much about apart from analgesia, and catastrophic hemorrhage. And that just fits into that nice Atom FC mnemonic. When you're assessing kids, don't be a fake. Don't tell them lies. Don't try and pretend that you're like the most kid-friendly person in the world if you're not. Be yourself. They'll know if you're not a kid-friendly person, and they won't really care. But if you try to be, they'll pick up on that, and you'll lose a bit of trust. But if you're yourself and you just approach them with complete honesty and a thorough professional manner, they'll trust you, and you will get everything out of them that you need to. The worst thing to do, though, is to lie to a kid because they'll pick up on it straight away. If you need something to talk about because you're not used to talking to kids, then just have a look around them like you would do with an adult and see something, a toy or their clothes or something, and just start talking about that. They'll love it, and they'll engage with you straight away. And that can be the difference between you winning and having a hard job. And then the next thing is have fun, because don't knock it till you tried it, but remember the child is your patient and they should be at the center of your interactions, and they're kind of programmed to have fun. It's not their parents you're there to treat primarily. And in the same way, you don't talk to adult patients' relatives instead of the patient first. The same applies to kids. And this also will help you to relax a little bit and that's important because if you're relaxed, the child will be more relaxed than if you're on edge. And they'll be more compliant, they will have less pain, they'll be much less scared, and you will perform better because if you're just constantly swearing in your head, it takes up your bandwidth, and panicking and being scared doesn't help you, your colleagues, or the patient. So why waste your energy? The scene management dynamics are like next level easier. Just keep verbalizing your head, as long as it's not swear words. Include appropriate people like the parents or teachers or bystanders that are carers, and there will be more use if they're almost in your way. And you may need to allocate a team member to talk them through what's happening in a structured way. But it will really, really help. Always call mum and dad as well, because that just helps them remember their role and responsibilities in that sort of scenario. And you'll find that if you just relax, have a little bit of fun, and talk to the kid like they're your main patient and nobody else is around, but also verbalize what's going on, everyone will be much more compliant and it'll be much easier to manage the situation. You'll also feel a lot better, and that's really important because you don't need that extra drain on your bandwidth worrying about what you could be saying or doing. So after we've assessed a child, we need to treat them. So I'll go into a little bit more detail about some of the differences here, but you'll see that actually a lot of the differences aren't really differences, they're just variations on a theme. And you would find that in adults as well. And the treatment is the bit that pediatricians go on about. But remember, they don't treat adults, so they don't really recognize the parallels all the time. So guess what? There's no difference in what you need to prioritize and do here. It's basically scaling to size with a couple of variations. So catastrophic hemorrhage. Uh, this is a QR code to a tutorial, which is commissioned by the American College of Surgeons for KidConfident to produce. It's available online and it's free as well. But basically, your catastrophic hemorrhage management involves direct pressure on wounds, tourniquets, trauma dressings, packing. It's just the same as in adults. Don't take my word for it, though. The American College of Surgeons have heard all my spiel and have completely endorsed this presentation, which is, well, it's all their material. Airway, we hear a lot about differences in pediatric airways compared to adults, and that does put some anxiety in people. But remember, most of the anatomical airway differences don't actually matter unless you're going to intubate. Doesn't matter if they've got a large tongue, a long floppy epiglottis, and funny shaped larynx, and where the narrowest point of the airway is. If we're not going to intubate them, which most of us wouldn't do unless we're pushed to, especially if you're not a critical care team, it doesn't really matter. What does matter is positioning. So jaw thrusts are good, and the younger the age of the child, the less of a sort of neck extension sniff in the morning air, and the more neutral position to get their airway patent. Head tilt, chin lift is okay in older children, but again, you don't need to yank it back as far as you do in an adult. And in trauma, would always advocate doing a jaw thrust anyway. Jaw thrust is a jaw thrust, and they're good. Same. Size does matter though, and so measuring things like oral airways properly is really important, because if it's too long, it will cause an obstruction. If it's too short, it won't help, or it might cause more of an obstruction. So it's important to deliberately measure the size of your airway adjuncts. So using, as in the picture, angle of the mandible to the midpoint of your incisors to select the correct size. The other slight difference with children compared to adults is you don't stick it upside down and twist it round. You should do it under direct vision, preferably with a tongue depressor, because you have them available. But put it in the normal way round and see that it doesn't cause any damage to the roof of their mouth as it's going in. The most important thing to remember, though, is see what works and go with it. Juxtaposition to effect, so looking for chest expansion, mask fogging, end tidal concentrations, the same as you would do in an adult, because remember that adults aren't all the same sizes either, and you might have one adult who responds to one airway maneuver or one position better than another, and using things like blankets to bolster shoulders, and just playing with the position and seeing what works is what you do. You're really good at doing that with adults, and it doesn't phase you at all. But for some reason, because they're littler people and we've got that they're not small adults in our head, we can't do that. We have always to look for the perfect position. So ignore that, see what works, and go with it. It doesn't matter if it's not the same as a textbook. If it works and they've got an airway and they can get oxygen in, carbon dioxide out, you're winning. So moving on to B, always give oxygen. Children have a faster metabolic rate than adults, and they need oxygen the same as adults do, especially when they're in stress states like injured. If they've got a tension pneumothorax, decompress it. The landmark is exactly the same, second intercostal space, midclavicular line. And I know that there are some concerns about using this landmark in small kids because of this thing called the thymus gland, which disappears as you get older, and the risk of injuring it causing bleeding. So some people would advocate a lateral approach for decompression. Other people have a concern that the heart lays more laterally in that same age group, because of the formation of the diaphragm. And so then the risk of you injuring the heart is greater than in an adult if you're doing a lateral decompression. The thing to remember is that it doesn't really matter. There's no right or wrong answer. As long as you get the air out of the wrong place in their chest, and allow their heart to beat, by decompressing attention, you're doing the right thing. My personal feeling is that fanging the thymus gland is going to cause less bleeding than banging a heart, and is going to cause you less problems. So I personally go for the anterior landmark, second intercostal space, mid-clavicular line. I take the back of the cannula off and put a saline-filled syringe on the back of it, and I'm drawing back on the syringe as I introduce the needle, and as soon as I draw back air, I slide the cannula off, and that reduces my risk of damaging any internal structures. The important thing is you need to do something, and if you're decompressing tension, everything else can be fixed in hospital. Give analgesia for chest injuries. Don't be afraid of doing that, the same as you would do an adult. If they've got smashed ribs, it's going to hurt them to breathe. They're not going to breathe effectively, and they're going to become hypoxic. So don't be afraid of giving analgesia for chest injuries. And then the 3 Rs is something that's talked about to optimize breathing, and that's repositioning the airway and adjust it if you needed. Go with what works. Repositioning the child, so the uninjured side, the good lung, is up, or if you can get them in a seated position, get them in a seated position. And then obviously always remove restrictive clothing or heavy objects from their chest so they can actually move their chest as well. So I know I'm teaching you to suck eggs so far, because this is all the same stuff that you would do in adults. It's just scaled down to size. But that's the point. See, got to get some vascular access, and that can be intravenous or intraosseous. The guidelines say you have 2 attempts at intravenous access, and if you can't, go for a bone gun or something. Go use your easy IO. This is a poster that one of our HEMS paramedics at the air ambulance did for KidConfident and for the team at the air ambulance as well. Just shows you some of the extra landmarks. You can go over the distal femur. It's really useful, and it's really easy as well. Some people moan about growth plates and, oh, you could damage a growth plate and then they're going to have a wonky arm and stuff. But my argument to that is I would rather my kid grew up with a wonky arm than didn't grow up with a straight arm because somebody didn't put a easy IO into a growth plate when they needed to have vascular access. Give fluid boluses for hypotension. Depending on who you listen to, it's 5 or 10 mils per kilo. 10 mils per kilo is for everything else, and there's nothing wrong with giving 10 mils per kilo for trauma either. And a rough calculation for working out their blood pressure, if you don't have a memoir, is twice the age plus 70, and that will give you a rough ballpark of what their systolic blood pressure should be. You also need to control bleeding from long bones, put a pelvic binder on. If they're really little and your pelvic binder doesn't fit them and it's not going to be effective, then improvise, use anything you want. Just put it around the greater trochanter, same as you do in adults, and put it tight to close any open but pelvic injuries. Another trick that we do in operating theatres with all age patients is to tie their ankles together, because if you think like pelvic surgery, somebody's got a binder on, that has to come off for them to have an operation, and the orthopedic SHO usually ends up at the bottom of the operating table holding their feet together with a wrap around their ankles, and that is enough to close the book of the pelvis, close the open book pelvis, and tamponade any bleeding whilst they're being operated on without a binder. And then obviously external bleeding from wounds needs stemming. D, we move on to our head injury management, spinal injury care. It's all the same as it is in adults. We don't like collars in any age group of people unless we really need to put them. Blocks and tapers, fine if they'll tolerate it. But if they're moving around freely, moving their arms and moving their neck around, don't pin them down to a board. It will just annoy them, the same as it annoys adults as well. And then glucose. This is something that it gets me on another little rant, to be fair. That we hear that glucose and BMs aren't a priority in resuscitation or major trauma, but the whole point of us resuscitating someone and looking after their head injuries and things like that, remembering that most children will have head injuries as their mechanism of injury because they've got that big floppy head that we saw at the beginning, and your brain is greedy. It uses more oxygen and glucose than any of the other organs in your body, and kids have small livers which are not fully matured. Obviously, the older they are, the more matured it is, but they don't store much glycogen, so gluconeogenesis and their ability to maintain their blood glucose does run out of steam quickly in stress states. So checking the BM and correcting it is really important for optimal head injury management and trauma care in general. So don't forget sugar. And then giving analgesia comes under D as well. And this is something that we've developed with the Paediatric Blast Injury Group and University of Bath as well, is this approach, the pain approach, where we prepare, assess, intervene, and think of the next steps of treatment. And for us in the pre-hospital environment, the next steps would be movement and moving them from where they're laying onto a scoop, onto the ambulance, and transferring them to hospital, and preempting anything that's going to cause more pain and doing something about it before they get the pain. And then there's these three pillars of interventions that is, again, we've written it for children, but it does apply to adults as well. You have your physical, pharmacological, and psychological interventions, and they're all built on the core principles of paediatric care, which is creating a safe environment, respecting the child, making them the center of your interactions, acknowledging any of their spiritual and cultural practices, but also involving friends, family, and caregivers, being honest, and providing a sense of security and comfort. If you've ever had a kid at nursery or been to a nursery, you'll know that cold compresses rule and they fix most things. So that's an example of a physical intervention, but then putting cling film on burns, splinting limbs, and immobilizing them in comfortable positions are other examples of physical interventions. You know all about your multimodal analgesia. You're giving them the paracetamol, ibuprofen, 3/1s, and morphine. You can give that orally or intravenously. And psychological interventions is not sitting down with them and asking them about their previous childhood, but things like distraction, reinforcing that they're doing well, they're being brave, and reassuring them that you're doing the best for them, and you're going to get them to hospital where they're going to carry on being looked after. And those things are really, really powerful, actually. You can chuck as many drugs as you want to any patient, and they won't work as well as if you use this three-pillar approach to pain. To help with this, we've got another preparation card, and this just helps you consider the different aspects of the three pillars, so you can work out their weight from their age, have a plan for physical interventions. So if you know that they've got fractured limbs, if they're likely to have fractured limbs, or if they've got likely to have burns, that you could apply cling film dressings and cooling the burn, cling film dressings, and splinting bones. You might have kids of your own, so you might have access to YouTube or some Peppa Pig or whatever on your phone, and that actually is really powerful. I've got a few games on my phone that I like to give them to play around with, really simple ones. One's called Fluid, which just makes pretty patterns on your phone, and it's free to download, so that's a good one. Assessing pain scores is best practice, so you can remember to do that if you can, and then you've got your doses there as well, so you can calculate what sort of doses you're going to give to the children, and naloxone in case you overcook it, which you're really unlikely to be fair. And then E. Now, E stands for everything else is the same. Splint limb fractures, because it reduces blood loss and it causes analgesia, pain relief, dress the wounds. Not only is that a good thing for cleanliness and reducing bleeding, but it reduces the visual stimulation that something is wrong. Package them nicely for transport, keep them warm. And I'm going to deliver again here because it's not very good at producing heat in younger kids because it doesn't have much glycogen to turn into glucose. So their thermoregulation is more efficient. So you do have to really suffer on the back of the ambulance and turn the heating up really, really hot, just to try and keep their thermoregulation going. And this all leads into that trauma triad of death, which I know that you all know about. And you have severe bleeding, it reduces perfusion to your tissues, and that leads to lactic acid production, which changes the pH of your blood, which makes your clotting cascade and your platelets not work properly. So you become coagulopathic. But then, because you're also not perfusing your muscles and tissues very well, you become hypothermic, and that further produces lactic acid production and anaerobic respiration, which makes you more coagulopathic. And before you know it, you're in this horrible mess when going into DIC and all sorts of things. You get the idea. They warm up, they cool down faster because they've got a relatively larger body surface area, the smaller that kids are. But that also means they've got a relatively larger body surface area to warm up as well. So keeping them warm is really important, and it's really easy to do as well, because they have got a bigger surface area to absorb heat from. See, easy. So when you've got your next major trauma patient, be kid confident, because you can do everything that you need to do. It's just a little bit more attention to detail, and that's it really. It's all easy, and it's all the stuff that you already know. Now, we're going to talk about traumatic cardiac arrest in kids, because it happens, and this is where even I tighten my grip on my bowel contents. But it's it's a good thing to talk about it, and it's a good thing to understand that actually the same things treat traumatic cardiac arrest in children as they do in adults. And there are only four reversible causes of traumatic cardiac arrest, which are hypoxia, hypovolemia, tension pneumothorax, and a tamponade. And that is literally it. Adrenaline and CPR is okay if you've done everything else, because adrenaline isn't actually what makes a heartbeat. It's blood carrying oxygen and glucose what makes a heartbeat. So that's what you need to focus on. And my little recipe is tube or eye gel down, long bones to length, pelvic binder on, decompress both sides of the chest, and then a thoracotomy and proceed, because that's the treatment for a tamponade, and I can do that. If you can't do that, then you need to start thinking about where you're going to have that done. Is that going to be a pre-hospital intervention because you've got a critical care team heading towards you, or is it going to be quicker to move them to hospital to have that done? Bearing in mind that it needs to be a hospital where they can do that and the people there have the skills to do it. But this is the same in adults as it is in children, and you have the same thought processes and you do those same things. So it's the same thing for all ages. And this is the hot approach that everyone talks about, not giving adrenaline and doing CPR. So please don't jump straight on the chest. You need to do these things first, and remember, hands off and hot. Oh, and it's going to flash just to reinforce it. There you go. And this is a really nice quote from Phil Godds, who I think he still works for Great North Air Ambulance. Your patient in PEA arrest is not dead. They're trying really hard to stay alive. So work on them like a ninja. Train hard, fight easy, and treat kids like adults is how I would summarize that. And this quote is especially true in children. So don't give up, stay focused, stay calm, and win. And remember, you can always get help. We were talking about doing a thoracotomy just now. And if you don't have the skills to do that, make sure you are putting an early call in for help if they've not already been dispatched. And that could be an enhanced care team, a critical care team, HEMS basics, or specialist or advanced paramedics, or operational officers to help you make those decisions and take that bandwidth away from you. They bring you some advanced clinical skills. They might bring surgical interventions. They might bring blood, but they will definitely bring some experience as well. And that's all helpful in these situations. Can't guarantee they're all as beautiful as my colleagues at the air ambulance service though. So then the last thing that we talk about is scene management, because managing a patient is only part of the story. And this is something that causes some anxiety when children are involved in incidents, especially traumatic incidents. There are here some important additions to your usual care, and I'll summarize them quickly because a lot of these things can lead to whole like webinars and lectures and books and everything else of their own. So parents, bystanders, and caregivers, they can be really difficult to manage. they may be angry with each other because of what's happened, and they might at the same time be feeling guilty and upset, even if it's not their fault that the child's got injured. So explaining what you're doing helps calm them down, and it helps focus them on what's important at the time. Calling mum and dad, as I said, calling them mum and dad helps remind them of their role and their responsibilities for their child in the situation, and focus their attention on the child and the care that's needed, and hopefully calm down. And actually, I found that does work a lot, in the same way that when I'm feeling a bit jovial, shall we say, and somebody turns around and calls me doctor, it makes me just focus a little bit. Reassurance is a really important thing as well, and it helps relieve any guilt. It diffuses so many difficult scenarios, and it's a really important thing to reassure parents or teachers or carers that you are helping, and you are trying to do the best for their child. And that's what you need to focus on right now. Don't let their questions and their want to comfort their child get in the way of your care, because they can be comforting without having to hold on tightly to the child or getting in your way. But there is really good evidence that parental presence during treatment of severely ill children, especially in resuscitation, is good for the child and good for the parent. But there may be some times that you want to create some distance between them. So when you might not want parents to be present, we spoke about, and this isn't the whole topic in itself, but remember when I said that it's under ones who get injured the most, and a lot of these are from suspected parental abuse. And we saw that chart where 50% of under ones is suspected parental abuse. But it's not limited to under ones. So things like having multiple injuries, old injuries, if you've had recurrent calls to the same child, or you learn that they've had recurrent visits to hospital, you're hearing stories that don't quite add up, or there's injuries sustained from activities that the child is not developed enough for, like toddlers opening locked windows after climbing up a sofa when they probably can't even crawl yet, or changing behavior around certain adults or parents. When they come into the room, you notice that the child changes their attitude and the behavior and the way that they're looking and talking and interacting with you. They're sort of some of the clues that something might be up. And you need to just be aware of that, and you will need to raise a safeguarding referral for your trust. And I would always advocate telling the nurse in charge when you get them to hospital. Now, if you don't want if you've got any of these situations and you don't think it's good to have the adult there because the child's not interacting with you as well and is affecting your ability to treat them, then just get in the back of the truck with the kid. If the parent is insisting, then you have to insist that the adult goes up front and travels in up front, and make up some sort of excuse like safety and needing to work during the transfer, and they need to sit up front, and that's normal. Shut the hatch and offer kindness to the child. You don't have to interrogate them and find out if they have been abused or anything. You're unlikely to find out. But if you offer them kindness, comfort, and you do your job of trying to help them with their injuries and their current situation, get them to hospital, then you will find that they might open up to you, and that can give you something to pass on in your safeguarding referral. Never make any false reassurances, and tell them, if they do tell you something, you will have to let other people know, so that those other people can help them stay safe in the future. And that is perfectly reasonable, and is the right thing to do. If you do raise a safeguarding plan, and and there is no safeguarding issue, then that will get found out, and the parents won't hold that against you, and it won't be a barrier to them accessing care in the future. And I can tell that from personal experience. When my little boy had croup and I took him into the hospital because he was a bit blue, and I know as an anaesthetist that I have to stay calm and all the rest of it, so that he doesn't get more wound up and put more drag on his more make his breathing worse. And I did that, and I was very calm on the outside. And one of the nurses in the emergency department, who didn't know me, to be fair, put a safeguarding referral in, which was batted away by the nurse in charge because she did know me and you knew what job I did, and it was all fine. And I would rather that that nurse had been worried that I care enough about my kid who was blue than just assumed that I knew what I was doing, because I might not have done and I might not have cared. And so then my little boy would have needed some more help. Remember that children love their parents even when they're being abused as well. So they won't want to get them into trouble. So that's why it's important to just be kind to the child, offer help and safety, but don't make any comments that suggest the parent will be in trouble because of what the child says. And as I said, inform the senior ED nurse and complete your trust safeguarding referral. Even if ED say they will take care of it, if you have a suspicion or you've recognised something, then it is important, I think, to do that yourself as well. Destination is a important thing. We know that 40% of children with major injuries don't get taken to a paediatric major trauma centre, and that's for a number of reasons. A large proportion of them are taken to hospital by their parents in a car, so we can't do anything about that. But then equally large proportion get taken to a trauma unit by emergency services because it's the nearest hospital and it's thought to be better to get them to the nearest hospital than the most appropriate hospital. And we know from adult care that trauma centres do have an effect on outcomes, a positive effect on outcomes, and the same is found in children as well. And that secondary transfers are a way of delaying definitive care and reducing positive outcomes in our patients. So children with traumatic injuries do need to go to a specialist centre that manages them more regularly, remembering the tiny number of paediatric traumas compared to adults that happen. And that's a children's MTC. Now, just to annoy us, they're not always co-located with adult MTCs. Even in the same city, which has an MTC, you might have to go to a different hospital. And it's really difficult sometimes to find out where you should be taking someone. And although there's millions of maps and guides about adult trauma centres, there aren't for paediatric ones. So we've put one together on Google Maps, which is available through KidConfident site. And you can download it and save it into your Google account on your phone, and even get directions to where it is. So if you're not sure, you can look it up and you can take them to the right place. All of the trauma guidelines in all of the trusts in the UK would support you taking a child with major injuries to a children's major trauma centre. And that also reinforces the importance of asking for enhanced care teams or critical care teams to come and support you, even if it is just with a longer transfer and bypassing a local hospital. So there you go. I'm done rambling. And the summary is that there are some small differences between adult and pediatric trauma patients, but few of them really matter. Your assessment and treatment is basically the same, but scaled to size. And using aid memoirs is the way forward to reduce bandwidth and help you deliver really excellent care, which you're used to doing. Oxygen, glucose, and temperature need a little bit of extra attention. They just need checking and giving. And safeguarding should be on your radar, especially with the younger kids. But remembering that not only little kids need safeguarding. So please be confident in your ability to manage injured children, because I've come across lots of crews who are absolutely bricking themselves and doubting themselves when they've got these injured kids, and they've done a fantastic job. And it is sometimes really hard to convince them of that. So please don't let that be you. Be confident in your abilities and deliver excellent care, which you're used to delivering to other aged patients. A little quick thing about resources, I'm plugging myself now. If you look on the KidConfident website, there is these trauma specific resources. Do have some other stuff as well going on there, and posters which just give you the headlines and some information about managing different aspects of trauma in children. And as Anna said at the beginning, our most recent poster was management of drowning in children, which was actually put together by one of the clinical directors in the southeast, and their team. And we've got resources from Stop the Bleed. We've got some other little tools like the Paediatric GCS score, which is basically the same as the adult one, but has an extra box in it for non-verbal patients. We've got pain assessment tools to help you figure out how much it hurts and give you a guide to sort of the analgesia that they would like. Vascular access. We've got our major trauma map, and one of my favorite resources is the Paediatric Blast Injury Field Manual, which is a free guide written by the Paediatric Blast Injury Group, originally for conflict zones and low resource settings. And it does cover trauma care, not just blast injuries, across the whole, from point of injury to rehabilitation. And it does have a really good section on pre-hospital care as well. So that is well worth looking at and getting hold of. It's free. If you have any questions or you want to develop your learning with pediatrics, pre-hospital care, then join our Facebook group where you can ask us questions and get answers. And that can either be on the group or by direct message, and we answer all the questions on the group. But if you send it by direct message, we keep it anonymous, don't worry. But if you've got a question about something pediatric, then it's likely that loads of other people do as well. So it's not just good for your own learning, it's good for everyone else's learning and developing their confidence as well. We also put on there resources, the e-learning stuff, and you get to test all of our e-learning resources for our new e-learning site that is getting put together as well, and give us honest feedback and tell us where's good and where it's not, and that's all good and for free. And then this is a QR code next to that for the Paediatric Blast Injury Field Manual for the latest edition of it. It is available on KidConfident, but they've got their own website as well, which they keep up to date, and it's available in like a million different languages. So if you fancy reading it in Mandarin, you can just download it in Mandarin from there. That's fine as well. And as I said, it's a really useful resource, just to have read, really. So there you go. In the context of trauma, children are small adults. They deserve the same standards of care as adult trauma patients. They need the same interventions as adult trauma patients. And I would like this to be your take-home message if you can't remember anything else. And that's it.